Good afternoon, and welcome to the Epilepsy Foundation of Connecticut webinar series. My name is Monica Anzalone, and I will be moderating today's webinar. For the purposes of sound quality, all of you should be in the listen-only mode, and we welcome you to use the chat icon at the bottom of your screen to type questions. Those questions will be answered at the end of today's presentation. Our webinar today is on the responsive Neuropace stimulator system, and it will be presented by Dr. Pue Farooque and Dr. Lee Gerard. A little bit about our presenters. Dr. Farooque is a faculty member at Yale, and she's been there since 2011. She's the current clinical director of the Epilepsy program and the Epilepsy Fellowship Director. Her clinical interests are epilepsy surgery, improving surgical outcomes, and transition of care from pediatric to adult epilepsy. Dr. Gerard is an assistant professor of neurosurgery, specializing in epilepsy surgery as well as functional neurosurgery. He is the chief of the functional and the stereotactic and neurotrauma sections of the Yale School of Medicine, Department of Neurosurgery. He's a member of the Yale Comprehensive Epilepsy program as part of the epilepsy surgery team, and he'll be joining us in a little bit. So I would now like to hand it over for the beginning of our presentation today to Dr. Farooque.
Hi, my name is Dr. Farooque, and as Monica stated, I'm one of the faculty members at Yale, and I'm going to be talking about responsive neurostimulation. Dr. Gerard will be joining us shortly, and he'll talk about the surgical evaluation for epilepsy as well as for the RNS system, and then go over some more of the kind of in-depth surgical questions that you may have. So I'm going to just start with a brief overview about epilepsy, who should get referred to surgery, and then we'll talk a little bit about the RNS system. So we're going to be talking about responsive neurostimulation. So as an introduction, epilepsy has a prevalence of about 1% in the world. So about 1% of the world's population has epilepsy. Majority of the patients are well controlled on medication. So about 70% of patients, whether it's on a combination of 1 to 3 medications, will be well controlled, meaning no seizures at all. However, about 30% of patients are what we define as medically refractory. And what that means is that you have failed 2 or more medications to achieve sustained seizure freedom. And this represents about 30% of epilepsy patients, and the rough estimate is about 750,000 patients. This group of patients has a higher risk of mortality, and given that subsequent trials of medications may not decrease or increase their probability of achieving seizure freedom, we need to think about other modalities, treatment modalities, in terms of helping and treating these patients to decrease their seizure burden. So the American Academy of Neurology recommends that patients with focal seizures who have failed 2 or more seizure drugs should be considered to a referral for an epilepsy surgery center to see whether or not what other treatment modalities may be available. And there's a multitude of surgical techniques or modalities that can be available to patients to try to decrease, so either decrease their seizure burden or to achieve seizure freedom. Unfortunately, only about less than 1% of patients are referred to epilepsy centers, and the number of epilepsy surgeries that are performed each year in the US is only about 1,500, and the delay to a referral to an epilepsy center is about 20 years. There have been numerous studies to show that there is a benefit to surgery over continued medication trials. One study that was done in Canada, which is one of the most coveted studies, that was a randomized placebo-controlled study looking at patients who underwent epilepsy surgery versus those who continued medications. At 1 year post-surgery, 58% of those patients who underwent surgery were seizure-free, as opposed to patients who just continued medical trials and treatments. Only about 8% of those patients were seizure-free. There's also been analysis looking over a multitude of studies to see surgical intervention versus continued medical treatment. And those who undergo a surgical procedure have shown to have higher rates of seizure freedom as opposed to those who just receive medical treatment. The likelihood that further medical trials will lead to seizure freedom after you fail those 2 anti-epileptic drugs is in the range of 5 to 16%. It's not 0%, so there is still chance that a combination of medications may be found, but it's much less probable than is a surgical procedure. So in order to evaluate a patient for surgery, there's a multitude of testing that needs to happen. Initially, we need to get an accurate history and description of the seizures. There is imaging testing, such as an MRI, which is a picture of the brain, and that's looking to see if there's an area of the brain that may not have developed or formed well, or there may be an area of abnormality that the seizures may be coming from. A PET scan, which shows us how well the brain is able to utilize energy. And typically in areas of the seizure focus or where the seizures are coming from, that area is not able to access and utilize the energy as properly. And you can see that on imaging scale, on the imaging scan for the PET study. Video EEG monitoring, whereas you get admitted to the hospital and you undergo continuous EEG monitoring, and that's where the electrodes are placed on your head. We're constantly recording your brainwave activity, and then there's a camera in the room so that we can record your seizures. So we can correlate what you're having at home in terms of your events with the seizures to the brainwave activity, so we have an idea of where your seizures are coming from. And then there's functional MRI, which is another imaging test, and that allows us to see where your language is coming from, what part of your brain you have language, motor function, as well as sensory function. And then neuropsychological testing, both visual and verbal testing, to help us to determine which side of the brain and area of the brain may not be as functioning as well, which helps us to, again, to determine where the seizures may be coming from. Once we have all this information, we're able to determine whether or not a patient is a surgical candidate, and then what type of surgery may be most beneficial for them. Dr. Gerard will go into further in regards to the invasive surgical procedures and the types of different surgeries that are available, but I'll talk specifically about Neuropace and after the implantation of Neuropace. So Neuropace is a system that we utilize once we actually know where the seizures are arising from. So we need to first determine where the seizures are coming from. And once we've determined where the seizures are coming from, we can implant the RNS device into that region. And what the device does is can detect your seizures that are arising from your brain itself. And what we do is we program the device to detect the seizures. Once the device has been programmed to detect the seizures well enough, then we can program the device to send a stimulation, which is the treatment, to abort the seizure from occurring, which then allows for seizure reduction and seizure freedom. So once the device has been implanted, patients will go home with a computer, which is called a remote monitor, and a wand. And what that is the device is implanted in your brain, and so you place the monitor on top of where the device is, and then that wand downloads all the information onto your computer. And that device stores all the data and all the detections that the device has been triggered upon to detect. So all the seizure activity is stored within there, and then it gets transmitted to your computer. Afterwards, you have to then take your computer and transmit it over, plug it into the internet so that it can be transmitted to the central database so that we can review all your data in real time, and also remotely during your clinic visits or even prior to your clinic visits, so we can understand what is happening with your seizure frequency and also what your seizures may look like to help us with detection. So initially after implant, in the post-operative period, we usually obtain about a 4 to 6 week baseline of just data on seizures. So we need to know how frequently are you having seizures, what your seizures look like on the EEG itself. We ask patients to maintain a seizure diary, so just to count the number of clinical seizures that they're having, documenting the time and the day, and a description of the seizures. During the seizures, we ask that there's a magnet that's given, and there's a picture of that right here, where you swipe the magnet every time you have a seizure, and then the device is told to store that data. Anterior, you place the wand on the device itself, and then you transmit the data that was stored in the device to your computer. And then to upload that data weekly via the internet to our central storage unit so that we can look through the data that's been collected, so that in clinic we'll know how best, once we have the data, then we'll know how best to either change the detection setting rates to help the device to detect the seizure better, or if we are detecting the seizures well enough, then we can begin treatment with stimulation. So in a clinic visit, what typically happens is that the clinic visits are usually an hour long. We review all the data that you have uploaded through the time from the last visit. Initially, in the first stages, that will help us to program the device better to detect your seizures so that we can detect your seizures right at onset. Because the earlier you detect your seizures and the earlier then you start deliver stimulation or therapy, the better chance we have of decreasing your seizure burden and also rendering you seizure-free. Once we've gotten to the point of where we are detecting your seizures very well, then that's when we can start to initiate therapy. And typically this is all done in the office visit, where we'll test the stimulation parameters to ensure that you're not having any side effects. Some patients can state that they can sometimes feel the stimulation at times. They may see a flash of light, or they may have some sensation that they feel. Typically, for every pattern that's detected by the device, you will get 5 treatments. So you'll have 5 stimulations in a row. And that's typically how the device works. So once we detect, we've set the device for proper detection, then we would initiate treatment. And based on your response to the treatment, we can either escalate the treatment, so increase the current that we're using to stimulate or to abort the seizures. This is a recording, just an example of a recording of a seizure that we can obtain from the data that is transmitted from the wand and then uploaded weekly. And so this helps us to see, in which part of from which area the seizure is coming from. And then it helps us then to program the detection setting, and then from there to set the treatment options. So RNS was approved in November of 2013, and it's approved for patients of the age of 18 years and older who have medically refractory epilepsy. And again, medically refractory epilepsy is any patient who has continued seizures after failing 2 medications. Patients can have up to 2 different areas of where their seizures may be coming from, or their seizures may be coming from an area where there's overlap of either language or motor function, and they are not a surgical candidate in terms of resection, so you can't remove that area because of loss of function. So then they would be a Neuropace candidate, because Neuropace does not disrupt any function, but it can treat your seizures. Based on the studies, as you can see for long-term follow-up, at 7 years, there's been a reduction of seizures by 72%. So meaning that patients who have had this device implanted, the longer you have it implanted for, the more seizure reduction you have through the years. So at 3 months, the decline was about 40% in seizure frequency. And then at 7 years, you can see there was a mean reduction of about 72% of the seizure frequency you had. And more than 50% of patients respond to Neuropace. There's been no cognitive decline seen with patients with Neuropace, so meaning no change in their memory at all. It seems that there may have been some benefit to patients in regards to naming, as well as in terms of for verbal learning, so remembering words and being able to recall lists. Patients have reported improvement in quality of life. There's been no change in mood reported or increase in suicidal thoughts at all. Complications of the device itself that can happen during the surgery are infection, headaches, and some areas of numbness in that area where the device was planted. As I mentioned before, sometimes during high stimulation parameters, patients may feel the stimulation or see a flash of light. And implanting the Neuropace has also shown to decrease your risk of mortality and your risk of SUDEP. So I wanted to just review a little bit of our experience with Neuropace at Yale. These are the patients. We currently have 23 active patients who have RNS implanted, and they've all been implanted for a variety of different reasons. Most of the reasons have been because the area where the seizures are coming from have overlying function, whether it's speech or whether it's motor or sensory function. And so that's the reason why, since we were unable to remove that area of the brain, RNS was implanted. For some patients, their seizures were coming from two different regions, neighboring regions that they were coming from. So given that you can't remove more than one area of the brain, RNS was used in those patients as well. So this is just a schematic showing which lobe our patients have been implanted. Majority of them have been temporal. However, we have had implants in the frontal lobe, parietal lobe, and occipital lobe, and we've also had some patients be implanted in the thalamus as well. This is our current treatment response. So you can see we actually have 6 patients that are seizure-free with our RNS device, and majority of patients have had reduction in seizures, typically greater than 50%. And then there are some patients that have had less than 50% reduction, and about 2 patients that have had no change at all. And this is showing you the response by where it was implanted. Our temporal lobe patients have had the greatest rates of seizure freedom as well as seizure reduction. However, the other areas too in the frontal and parietal lobe, as well as the occipital lobe, do have patients with seizure freedom and also with seizure reduction. So the summary of the Yale experience is that about 74%, we have a 74% responder rate, which means that 74% of our patients have greater than 50% seizure reduction. It seems that RNS, in our experience here, has worked better for temporal lobe patients rather than frontal, parietal, or occipital. However, the numbers are small, and so it's hard to determine whether that's actually of statistical significance. Another thing that we found at our center is that the addition of ONFI with RNS has proved to be very beneficial in the treatment of patients that have the neurostimulation. So I will start discussing some of the surgical evaluation before Dr. Gerard comes in, and then he can take over from there.
Dr. Farooque, I think he is on.
I'm sorry?
Dr. Gerard, are you there?
No, he's not here yet.
Oh, okay, I saw him. Sorry, go ahead.
Oh, he's here, or?
Well, I saw him log in.
Oh, he did log in?
He did, but I'm not hearing him, so
I
guess you can just start.
Do you want me to just start, or do you want me to take some questions based on what I said?
Sure.
Yeah, we can do questions, and then maybe he'll come in at that time.
Okay. Do people have questions? If anyone has questions up until this point, you can feel free to type them in the chat section, as I mentioned earlier at the beginning of the webinar. I know it takes a few minutes, that's the only thing.
That's okay.
Yeah, you might want to just continue going, Dr. Farooque, just because I don't want there to be too much. This is being recorded, so too much dead silence.
Pue, are you able to hear me?
Yeah, I can hear you. Oh, you want to start?
Sure, I can do a few slides here.
Okay.
This is Dr. Gerard. I'm one of the neurosurgeons that works with Dr. Farooque. Just wanted to quickly go over some of the paradigm that we use for evaluating patients and the procedures. So this is sort of the standard outline for patients who undergo surgical evaluation. Did you talk about phase 1 evaluations, Dr. Farooque?
I talked about the video EEG monitoring and the imaging.
Yep.
Yeah.
Right. So all of that data that Dr. Farooque has talked about is put together, and sometimes everything on the left of the screen you see where it says concordant data, sometimes all of that data lines up to the same part of the brain, and or there's actually an abnormality in that part of the brain that can be seen on MRI scan. And in those cases, we can use this information to go direct with what's called direct substrate surgery. The other case, which actually these days is more common, is if everything isn't all lining up in the same location, or there isn't a clear answer on the MRI scan. And most of the time, these patients will undergo the intracranial monitoring so that we can help to localize the seizures. Can you advance the slide? This is just a slide, again, emphasizing the fact that surgery is highly underutilized in the United States, and that any patient who's failed 2 medications should be referred for evaluation. And this is emphasized with the data on the bottom, which shows that despite all the awareness outreach that we do, that it's not changing much. So every year there's between 100 and 200,000 epilepsy patients who are surgical candidates, and a small fraction of those patients, only in 1990, only 1,500 are getting a lobectomy, and that didn't really change much. Those numbers aren't statistically significant even a decade later. Go ahead and advance. So with the workup, if we do an implantation and figure out where the seizures are coming from, sometimes we can find what's called a localization of onset. And then if this is in a single region, then the question becomes, does this region overlap with functional cortex, or is it something that could be safely resected? And with resections, we tend to get better, overall better percentage outcomes of seizure freedom. But obviously, it's not worth it if it comes at the expense of function. And these days, sometimes we'll try to use the laser if we think that if we could get to the deep structure, and we didn't injure the superficial structures on the way, then that's something the laser can help us with. If it's more than one onset zone, or the onset zones overlap with normal functions, such as with motor or language, then we don't resect that part of the brain. And that's where the Neuropace system, the responsive neurostimulation, can be very useful, because we can use the stimulator rather than having to do a resection. Go ahead and advance. So this is a full list of the surgical procedures that are available these days. We've had the resective surgeries available for a long time. And now we've added the LITT, which is the LITT, or the laser. It stands for laser interstitial thermal therapy ablation. Hemispherectomy is the removal of an entire brain hemisphere that has seizures. It's mostly done in children. And then there's disconnection procedures, where we can try to disconnect different parts of the brain, such as with the corpus callosotomy or the multiple subpial transections. Not nearly as successful as the standard resections. And then there's the stimulation. The vagal nerve stimulator has been around for a while. It does okay, but the newer stimulation devices, such as the Neuropace responsive neurostimulation, are much more effective. And deep brain stimulation was recently approved as well. Doesn't have the track record that Neuropace does, and it's a different approach. Go ahead. So this is sort of a picture of what a standard lobectomy looks like. And on the right side of the screen, the structures that are very medial part of the brain, which are on the far right, are what we're actually after. But you can see one of the issues is we have to take all this cortical brain out of the way to get there. Go ahead. This is an example of a disconnection where we make little incisions in the brain, and the idea here is to disrupt connections between different parts of the cortex. Next slide. And now some examples of some of the newer techniques we have. We have a ROSA, which is a stereotactic robot here that allows us to put in several electrodes stereotactically in a minimally invasive fashion. One of the ways we can minimize the invasiveness of our procedures. Go ahead. And then the Neuropace. This is a picture of what the Neuropace looks like. This is an example. So the electrodes are placed onto or into the brain, wherever we think the onset is, and then connected to the device, which is implanted in the skull. And then on the right are some of the recordings from the device itself. And I think the next slide we'll talk a little bit more about that. Oh yeah, so one more slide. So this is another minimally invasive technique that we can use to put these devices in. This is a targeting system that allows us to use real-time MRI guidance to put in the electrodes. And in fact, here at Yale, we were the first place to use this device to put the Neuropace electrodes in, and are publishing a paper on this technique. Go ahead. This is just a picture of us utilizing the actual system, and that's a picture on the right of our actual operating room with the MRI scanner that comes to the table. So this allows us to get real-time images to know that our electrode's going right where we want it while we're putting it in. Next slide. I thought there should have been one more, Pue.
Maybe
Is there not one more?
No, that was it. Maybe
Okay, just go back. I'll talk a little bit about one more. Yeah. So on the right, one of the things that's really helpful with the Neuropace system is the fact that you get these recordings all the time. So the device is recording the activity that are going on inside the brain, and this can be extraordinarily helpful. Not only does it tell the neurologist when seizures actually happen, what time of day they tend to occur, but it can give data about even how well medications are working sometimes, and Dr. Farooque may be talking a little bit more about that. And I think that was all the slides that I had to you.
Yeah, that is.
Okay, I'll turn it back over to you.
Okay, thank you.
Yep.
So in conclusion, the basic concept from this whole talk is that patients who have continued seizures should be evaluated at an epilepsy surgical center to decide or to determine which surgical procedure may be best for them in reducing their seizure frequency and burden or achieving seizure freedom. As Dr. Gerard mentioned, there are multiple different modalities available now that can help patients, with RNS being one of them. And RNS is unique in the sense that it allows us, as Dr. Gerard stated, to have constant recordings of your brainwave activity so that we can better understand your seizures and understand how best to help you. In terms of getting the seizure data itself, we can see the effects of medication or the effects of the stimulation, and we're able then to fine-tune the treatment towards you. So that's pretty much the talk that we had prepared. Are there any questions?
While we're waiting for people to type any questions in the chat section, I just wanted to ask, is this something that is usually considered instead of or in place of surgery or vice versa, or is it just one of the surgical options available and not necessarily chosen before or after another?
So everybody has to go through the same evaluation to see whether or not surgery is possible. And based on the data that's collected, then we're able to determine what would be the best surgical procedure. So the thing is that everybody is considered for all the different options that are available, but not everybody may be a candidate for a specific option. Traditionally, resection has been the most common option that's been given to patients. However, resection is only able to be offered to a patient if you have one seizure focus and if the seizure focus is not overlying any type of function. So that can be memory, it can be language, or it can be motor function. So there have been a lot of patients that unfortunately have either, two different onsets of seizures, or they have their seizure onset overlapping with language or some other function. And so RNS provides an ability to treat these patients now that we didn't have before. Did that answer your question?
Yes, yeah. And would you say that more neurologists, even those that maybe aren't connected with like a research hospital necessarily, are they considering these options as well?
So I think a lot of this is education, because as I said, traditionally resection was the only thing available to patients. And I think now that there's so many other different modalities, especially with Neuropace and also with dynamic stimulation, people who are not candidates for surgical resection before are now candidates for neuromodulation. And I think neuromodulation has shown, specifically RNS, because we have longer term data with that, and there's some preliminary data with dynamic stimulation, that this can provide good seizure control to patients with seizure reduction and the possibility for seizure freedom, which they would not have been, could have achieved with either ongoing medication treatment or given that they weren't a candidate for resection either. So I think the field of epilepsy and epilepsy surgery has changed, and so I think neurologists within the community, a lot of it is education and allowing them to know that there are other treatment modalities available to help patients.
Thank you. We do have a few questions that have been typed in that I'll go ahead and just read to you, Dr. Farooque. One of them states, I already have the VNS implant. Is the RNS an option for me? And does the VNS have to be removed?
So just because you have a VNS does not preclude you from having any other surgical procedure. Without knowing specifically where your seizures are coming from and why the VNS was implanted, it's hard for me to say whether you would be a candidate for RNS, but you could be a candidate for RNS or you could be a candidate for the thalamic stimulation, and both would be used together. So the VNS would not be removed if you had RNS or if you had DBS. But you should be reevaluated to see if you would be a candidate for RNS or for DBS.
Okay, any other questions people have? And is it an option for people to bring this up to their doctor if surgery has not been something that has been discussed?
Yes, I think that's the thing of patient empowerment and understanding that when, if they continue to have seizures despite, as we said, 2 adequate trials of medication, that's when you can ask your physician to say, I would like to have a referral to an epilepsy surgery center to see whether or not any of these surgical procedures I may be a candidate for.
Good.
But patients can also self-refer themselves to Yale as well. We don't always necessarily need a referral from a physician. So patients can also self-refer themselves here.
Good to know. One more question. What is the average recovery time and how long till the RNS is turned on?
So for RNS, it is just an overnight admission. Typically, you're home the next day after the implantation itself. In terms of when the stimulation is turned on, that's a difficult question because every patient is different. It depends on if you're, it depends on the detection rate of, the detection of the seizures themselves. As I stated in the postoperative period, we need to gather data on your seizure frequency, how frequently they're happening, where are they coming from, and what do they look like on the EEG recordings. Once we have sufficient data, then we can program the device in order to better delineate and better to pick up the seizure at its onset, at its earliest onset. And then we have to test the device to ensure that that's doing that appropriately. Once that's happened and we're ensuring that we're picking up all your seizures, that we're picking it up at the very beginning of the seizure, then we can start the stimulation. So it may not be until at least 3 months post-implant that we're turning on the stimulation device. It could be sooner, it could be later, but typically it's about a 3-month wait before we start the stimulation parameters. But every patient is different and every patient is unique. And with RNS, that's very much so seen because every patient has a different seizure rate, they have a different seizure frequency, and their seizures look different. And so we tailor the treatment to the patient. And so it's whatever we think can be best, how we can best help each particular patient. So it does vary, and so I don't have an exact answer to your question.
Okay. And then for someone who, I guess they had a frontal resection done, would they be a candidate for RNS?
So depending on where their seizures are coming from, they may be, yes. But they would need a reevaluation to see now if they're continuing to have seizures, where are those seizures coming from, and what type of procedure would be best for them.
Okay.
But just because you've had surgery or you've had a VNS, that doesn't preclude you from also having a neuromodulation device like RNS or even the deep brain stimulation. So you could be a candidate, if you're continuing to have seizures despite the procedure you already underwent, you may be a candidate for one of these neuromodulations as well.
And is this something that replaced?
I'm sorry, you cut off. I didn't hear the question.
How often is the RNS replaced?
Oh, how often is it replaced?
Yeah.
So it depends on how frequently the device goes off, but usually about every 4 to 5 years. The company is working on expanding the battery life, but currently right now it's about every 4 to 5 years.
Okay. All right, and it looks like we do not have any more questions. So I just want to thank everyone for attending today's webinar and to inform everyone that this has been recorded and will be available on our website, which is epilepsyct.com, for future reference. And on behalf of the staff of the Epilepsy Foundation, I would like to thank everyone for joining us, for our presenters, Dr. Farooque and Dr. Gerard, taking the time to present to us today, and for all of you as well for viewing the presentation. Thank you.
Thank you very much for inviting us to do this as well.
You're welcome. Last long here, it was just right.